Yeah, thank you very much. Thank you, Sanjay. Thank you all. It was quite a nice debate here. So it would be difficult for me to rise the temperature at the same level. However, the comparison with statins, it's not that fair because we do not have surgery for cholesterol. So that's for surgery will last, that's for sure. Maybe with oncological programs, it is more fitting with comparison. Now, in this respect is also the technical improvements that we were working for, and sleeve, it is the topic I was asked to refer to. So it's nothing to disclose in this respect. If we look to the green line, we see that the growing of the usage of sleeve. And one might see that or understand that it was something that fueled up this growth. I mean, why this increase? What happened in the meantime? And if I may add to this graph, what happened as challenges. Initially, before 2010, there were so many risks, and some of you do remember that it was banned in some countries. Forbidden to do it in Germany. And then later on, the weight regain at the beginning of 2012-13 was the issue. And starting with 2016, we discussed about GERD, Barrett's, cancer. So all these were supposed to decrease the use of gastric sleeve. However, to complete this graph, the studies, the randomized control trials that we are discussing nowadays, 10 years after, even more, they started to enroll patients exactly at the first part of the journey of sleep. So there were plenty of improvements in between, and these marks are, for me, an opportunity to mention how much has been improved, how from the technical point of view, in order to perform the surgery we are happy to offer to our patients. And now still sleeve is on top. So I will refer not necessarily in this order about the technical modifications that were aiming to improve the outcomes, referring to stapling, oversewing, geometry, different taxes, volume, intrathoracic migration in order to prevent the early and long-term complications. Now, they are listed here, complications, including the weight regain, and at least some of these are related to technical issues. It's not the concept the problem, but there are some modifications that can be observed and improved, like gastric tube construction to prevent stenosis, obstructions, and hiatal hernia repair. I will not insist that much to stapling technology. You all know that significant progress has happened in the meantime, but our expertise in using stapling technology doesn't matter. Avoiding ischemic gaps, stenosis especially, and understanding exactly the biomechanics of the stapling technology, looking carefully for the final results of the stapled line, and trying to improve by using buttress, which is still questionable, not that much adherence. There are many studies, but trying to fit the technology to the very specific of that situation. That's an example of a sick antrum, and it was a laceration of the tissue. See that the movie is not running, and it is an oversewing, a need of oversewing. So oversewing was introduced larger and larger to protect the staple line, and I think this is a significant technical improvement, decreasing the incidence of leaks, bleeding, and reoperations, and it has been proved in seen many studies. This is only one collecting 17 randomized control studies, and you are aware of it. This is how it should look at the end. However, there is an increase of postoperative vomiting. We know this. There are some other advancements in stapling technology, like 4 rows on each side, the one fire stapling that you are aware about. We will see the results in this respect. In the meantime, the sequential firing is the common approach, and this is one of the studies advocating that if you fire only once, you got some improvements in time, length of hospital stay. But we care more about the stepper line in terms of what's happening not only in between the stapler, the firings, but also the bleeding at this line, and especially the geometry of a stomach that is forced to stay in what it should be. Can you help me? I hope I did nothing wrong. So that's it.
This happened to me last year, so don't worry about it. It's not you.
Yeah. Okay. So I have to reach that point. It was bleeding. So the next improvement that I would like to refer is bleeding. And in this respect, I'm sure that you are aware and already implemented an active search for the bleeders during the same surgery by something that was introduced more than 15 years ago by rising up the blood pressure during the same surgery and carefully observing what's happening. Really? Sorry? That's a video. Probably the system is not accepting videos today. What should I do? Maybe some microchips in the coffee in the morning. Yeah.
We'll give him a few minutes.
Yeah. Okay. So that's this can be an opportunity for me to ask you a question. How many of you are checking the blood pressure during the same surgery? So that's pretty the majority. So that's something very important to offer enough time for your patient to reduce the complications. And I think this is a technical improvement. Hopefully it will work. It is not working. Yeah, but it's I am keep pressing the video. I can describe the video, I can skip the video, but it's unfortunately I can. Okay. If it's, I'm sorry for this. Is an issue with what? Okay. Okay. So that some videos are working. So if you rise up, you get the opportunity to see the bleeders. You can place clips. Even if you use buttress, if you rise up the blood pressure, you can see the bleeders. So that's why it's not 100% protection with the buttress. But if you oversew, you got the opportunity to control all the bleeders from the stepper line. And this is what our study demonstrates, looking to more than 5,000 patients, comparing the patients where we rise up the blood pressure and heated all the bleeders with clips, while oversewing the entire stapler line. And it seems that it was a 5 times reducing of the risk of bleeding, postoperative bleeding, with 0 from stapler line. Of course, there are some other sources that can bleed after. Now, another improvement was to the obstructions, a gastric tube stenosis. It can be an issue, a technical issue, because we missed something, or it is a functional obstruction, naming here the coil sleeve, the twisted sleeve. And we should be aware this is also a technical improvement of how we are looking to the stapler line. From anterior, that we can swear that our fire will go for a uniform, not twisted gastric tube, but if you look from behind, you will see that you are much far away from the lesser curvature, so you need to fix it. Gastric volume, some improvement in this respect. This is how initially was looking the sleeve. Now we all agree that we have to take down the fundus. We decreased the bougie size from 60 initially, and there are many programs where the antral resection is offered. And if you look to the expected size and the volume of the stomach, we can see that in 2009 it was approximately 100 cc's. And we expect 1 year after to get double, which is normal. Double means 250. We know that at 250 cc's, your patient will not be protected. While a similar study performed in 2017 showed that the actual volume, it should be something between below 70 cc's, which make it double the size, which is exactly the volume we need to offer to our patients to protect in time. The antral resection, it was demonstrated that it's inducing more weight loss. So there are many studies in this respect. However, there are some issues with some vomiting after. And is it this due to antral resection, which is bringing even more extended of a stapler line, which interferes with the vagal branches and can justify the increased weight loss? But there is something with the geometry of the stomach, because we will expect to have this type of sleeve at the end. A L-shaped, narrow, long, uniform, not twisted, functional gastric tube with no intrathoracic migration. So we did our job. Will this sleeve stay as it is? Because we cannot be sure that we'll stay in that very position. And this is one example. I hope this video, which is nice, can be seen, hopefully. It's a twisted stomach that it is very much to the center part, median to the left, and it's migrated up into the chest. And why this is happening? Because we need to fixate somehow the gastric tube in order to freeze this position before consolidating the function of the sleeve. And there are some technical proposals in this respect you are aware about. This is the omentopexy. And there are studies in this respect showing that there is decrease in complications rate, in leaks, in bleeding, and also the vomiting, the torsion, because it's keeping the stomach in a proper position. And this is another example with multiple studies that are showing this consequence. But the omentum is a mobile structure. So what we are proposing and we're using for more than 10 years is the fixation to the prepancreatic fascia or coropancreatic ligament, which is exactly what you see in this situation. It might keep expected to keep the stomach into the abdomen to prevent the way up, which is the threat of intrathoracic migration and all the consequences that you know. So the important issue, and as a consequence, the opportunity for me to speak about improvement is GERD. And what is in the green frame is what we already fixed for the stomach to prevent the GERD with the cause at the stomach level. But what is still ongoing now is the hiatal hernia repair, especially the recurrence after and intrathoracic migration. And you are familiar with these images. They are pretty often seen. And we know that only the crura approximation, like you see in this slide, it is not enough. Some studies are demonstrating improvement, some others not after this procedure. And intra-abdominal fixation can help. But we tried to look what's happening in studying the position of the stomach immediately after the surgery. And there are some landmarks there. There are titanium medium large clips that we placed at the G junction. And immediately we observed where is the marker after the surgery. And we observed that in some cases was going up, and this was especially in the cases where we repaired the hiatal hernia. Because the scenario is when you have CO2 inside the diaphragm is up, you can swear that you placed your G junction at least 3 centimeters below the diaphragm. But when the CO2 is out, the diaphragm will go down and the migration initiated. So studying this effect, we tried to imagine what we can offer for the sleeve to stay there as a technical improvement. And you should not be surprised, because when we repair the hiatal hernia, we are taking down both leaves of phrenicoesophageal ligament, and we place nothing instead. So it's a question of time of going up immediately after the surgery, especially when the patient is regaining weight and the intra-abdominal pressure is there. So in this respect, there are some technical improvements that you are aware of, which is adding the fundoplication. No matter that it's 360, there is partial fundoplication, there are a lot of studies, a magnetic sphincter augmentation, a links, hooking down with the teres ligamentum, a modified heel gastropexy, and some other pexes that I already spoke about. And the who is working better. It is an opportunity to research more, and how frequently it can be implemented, that's another aspect. We will be looking for something that is going to be simple and with lower mobility, cost effective, largely accepted by the people, because fund application is effective. We have studies, but not that many programs are using this. So that's our concept that we introduced 6 years ago by reconstruction of the phrenicoesophageal membrane that we already took down by the time of hiatal hernia repair. And this concept was initially guiding the scarring around the esophagus with 2 points of fixation. I will complete immediately. And we compared the pre-pancreatic fixation with hiatal hernia repair with the same type of procedure, adding the reconstruction of phrenicoesophageal membrane. So together, more than 300 patients that were enrolled in this study, and now we have more than 5 years results. And we radiologically study where is the G junction, and we easily could demonstrate a reduction of 11 times of the risk of migration, with 6 times less intrathoracic migration after this simple procedure. That it's Of course, to be commented why we need to stitch the, is it allowed to stitch the esophagus to the diaphragm? So the nature built up a structure there that we already destroyed. Now 1 year after, we saw that we still have some migrations, and because of laceration or the rupture of this tissue, so we changed we upgraded the procedure. This is another technical modification, adding another point from 6 o'clock, 10 o'clock, and 2 o'clock, so that's more balanced the keeping of the GE junction down. And these are the 5 real results. The blue one is the cohort with hiatal hernia repair only with pleural approximation, demonstrating that almost 70% in 70% of the cases, the GE junction is in the chest with or without symptoms, and the highly protective mechanism of reconstruction. Now, to end up this presentation about technical improvements, I will not get into the details of what is Sleeves Plus. Has been discussed yesterday extensively. So a lot of technical modifications were introduced for sleeve to aiming better outcomes and all these challenges that we've had over the last 20 years were opportunities for us to improve, making nowadays sleeve a better version of the same procedure. And I am sure that the technical improvements are to be continued. Thank you very much.
Thank you, Dr.